So my name is Professor David Denning, and I work at the University of Manchester. And what I'm going to do today is to overview how common fungal infections are around the world. We've got some country-specific data and a lot of disease-specific data, but in addition there are global data. And we hope that this will be a useful introduction for you for understanding the size of the problem across the world. The intended learning outcomes today are to be aware of the vast spectrum of the different fungal diseases that there are, what the estimates are and some of the limitations around some of those estimates, what the key risk factors for the most common, particularly invasive fungal infections there are, and then we've got, as I say, some information on country-specific burden, although that varies a lot and we don't have all countries assessed. Now you can divide fungal diseases into 5 broad categories. You have superficial infections, which are certainly the most common, including toenail infections such as onychomycosis, skin infections or hair infections, tinnias, infections of the ears. Seborrheic dermatitis is common and actually one of the presenting features of HIV infection. And then there's fungal or mycotic keratitis, which is a very significant infection of the eyes. Also very common are mucosal infections, particularly almost all caused by Candida, and most by Candida albicans, oral thrush or candidiasis, or yeast infection, esophageal candidiasis, and vulvovaginal candidiasis in women, which may be single episodes or multiple episodes. Also very common at the top in green are allergic bronchopulmonary aspergillosis complicating asthma and cystic fibrosis, and alongside that, and very similar to that, is severe asthma with fungal sensitization. But there's also allergic fungal sinusitis and extrinsic allergic alveolitis, some of which is occupational in background. Then you have also in green on the far left chronic infections. Chronic pulmonary aspergillosis is recognised now as being a relatively common problem after tuberculosis. Aspergillosis bronchitis, particularly in those with bronchiectasis, for which we don't have good estimates. Coccidioidomycosis, blastomycosis, paracoccidioidomycosis. And then there is what we've now defined as neglected fungal diseases, sort of deep infections of the skin and soft tissues, mycetoma, chromoblastomycosis, sporotrichosis, and the superficial forms of histoplasmosis as opposed to the deep forms, or invasive forms. And then the ones that catch the imagination a lot are the invasive and life-threatening fungal infections, of which cryptococcal meningitis is a particular problem in HIV, invasive candidiasis in hospitalized patients, invasive aspergillosis, particularly in those with having had transported leukemia, but also others, Pneumocystis pneumonia, in AIDS particularly, mucormycosis, disseminated histoplasmosis, talaromycosis, and a large number of other rare pathogens which cause disease. So these 5 categories of infection are how it's best to think about fungal diseases generally. Now when you look across the world in terms of this, you have an annual incidence and you also have global burden, which is equivalent to prevalence, although it's there's an incidence which then gets treated and disappears over a period of time. And you've got the most common, which is skin, hair and fungal nail infections at about 1 billion people, and other relatively common infections like recurrent vaginitis in women with thrush and fungal Rhino-Sinusitis. And then you've got other infections such as talaromycosis and some of the rarer things as invasive disease, which are much less common overall. So many of these infections complicate other diseases, as I mentioned, and because of that, it's quite challenging to work it out. And there's surveillance really for candidiasis, but almost for nothing else across the world. And so the actual numbers are limited. So cutaneous fungal infections affect around 1 billion people. This was a piece of work published in The Lancet in 2012. Most common childhood infections, Otitis capitis is a very common childhood infection, around 200 million, mostly children. It varies a lot in frequency, so there are some countries with a few hundred cases a year and there's others with millions of cases a year. it's a person-to-person spread or animal-to-person spread. So sometimes this occurs in school outbreaks and so on. Onychomycosis is common and increasingly common in elderly people, and tinea pedis or athlete's foot is also very common, and actually a leading cause of lower lobe cellulitis, which is a common cause of medical admission to hospital as well. Now, when you look at the rates by country, you can see there's a lot of variability. So in Algeria, as one example, in Africa, Northern Africa, 10.6 per 100,000 people. In Burkina Faso, by contrast, about 6,000 per 100,000 people. And in Nigeria, 10,000 per 100,000 people. So this is a disease that's particularly common in children in sub-Saharan Africa. So fungal keratitis, the estimates for this are not as good as we would like, because there are not many countries where it's absolutely clear what the numbers of cases are. It overall probably accounts for about 10% of visual impairment worldwide, but it's usually unilateral, not bilateral. It's rare to get bilateral cases, but when patients have bad vision in one eye and then have keratitis in the other, they can be blind or nearly blind. There's probably over 1 million cases in Southeast Asia, although the numbers have been coming down, and some of these numbers here as high as 800 per 100,000 are numbers from 10 years ago, and more recently they've been a little bit less than that, which has been good news. We really have very little data from South America or Africa. This is a injury related or contact lens related injury infection, and contact lenses that are overused, or the sterilizing liquid that's not completely sterile is a reason for this, and it's typically in younger workers. And so you've got rates, for example, in Europe, which are really low, 0.03 per 100,000, which is really a low rate, whereas compared with Pakistan or Nepal, where the rates are really quite high, and then intermediate rates in other countries, although, as I say, these estimates are not terribly accurate, because you have to count this disease. There's no underlying disease account for this. Not published anywhere, but is an estimate of the fungal otitis externa or otomycosis. Around 10% of patients with otitis externa have fungal disease. It's usually Aspergillus niger, sometimes Candida or Aspergillus fumigatus or Terius. Acute otitis affects 1 in 250 people every year, and chronic otitis is remarkably common at 3 to 5% of the population. And so, given that the proportion of these are fungal, that gives you really quite a big burden of disease. And injury to the ear is a particular issue, and lots of earwax is another reason for this. Now, turning to chronic fungal diseases, chronic pulmonary aspergillosis is thought to affect around 1.2 million people each year after tuberculosis, but in fact we haven't got precise estimates, because it may actually be a misdiagnosis of tuberculosis as well, and it may occur during tuberculosis, but that's the number thought to be the case after TB. There's about 70,000 patients with pulmonary sarcoid complicated by chronic pulmonary aspergillosis, and many other diseases also are implicated in this disease. And when you look at the numbers across the world, you can see these rather astonishingly high numbers in Russia, because there's a lot of tuberculosis in Russia. Big numbers also in countries with large TB burdens, and then much smaller numbers in countries like Israel, Algeria and Canada, where the TB burden is much lower. Now, these estimates, of course, are mostly focused on tuberculosis, so if you have a lot of other chronic respiratory disease, the numbers may be a little bit higher than that, and it's actually difficult to estimate those accurately, and that we have found that challenging. With respect to the neglected tropical diseases, there are no very good counts of these infections. We think there's around 9,000 patients with mycetoma, which is typically in the lower legs, and there's a mycetoma belt across the equator and around the equator across the world. Most of the cases occur in endemic areas. Chromoblastomycosis is also of the same sort of order of magnitude, probably around 10,000 cases worldwide. There are more cases probably of Sporococcosis, but again, we haven't been able to count them accurately. And then some much rarer infections like subcutaneous zygomycosis and phaeohyphomycosis. This clinical example here is chromoblastomycosis from Brazil. Then you have the allergic fungal diseases, and there are many different allergenic fungi, and they, as I said before, complicate asthma and cystic fibrosis in particular, using a rate of 2.5% of patients, adult asthmatics, because this is rare in children. It does occur in children, it's just rare. There's thought to be about 4.8 million patients with ABPA, but only about 6,500 with ABPA complicating cystic fibrosis, so a very different range of numbers there. And in cystic fibrosis, it seems to be particularly common in late childhood and teenage years, and then slightly less common after that. And the rate per 100,000 varies a lot. So we think it's particularly common in the UK because we have a lot of asthma in the UK, but it's pretty common in India. And actually this number of 2.5% may be an underestimate of India because it's especially common there. And then in Tanzania, we don't have very good data because it's not a diagnosis made very often there. But when you look at the number of adult asthmatics, that's the number that you get, about 44. And so the rates do vary a lot, and this is really a function of the burden of asthma. It's not a function of the frequency of fungal sensitization or diagnoses of ABPA. And so some areas have very low rates of asthma. This is probably an artificially low rate in Uzbekistan, but you've got numbers around between the 20s and 30s per 100,000 up to the 250 to 300,000 in other countries. Now, asthma can be severe, and these are patients who come into hospital, need steroids very frequently, and it can be defined with these British Thoracic Society steps, and between 5 and 20% of asthmatics have severe asthma, depending on how you define that. And so when you look at that and the frequency of sensitization, which I'll show you in the next slide, you've got about 6.5 million cases probably, and it may be as many as 13 million cases across the world, with again rates dependent on the asthma numbers underneath. But there is an overlap between ABPA and SAFs, and we do call that fungal asthma as a way of sort of embracing all those things together. It's possible that some of the asthma-related deaths, and there's about 500,000 of them every year, are attributable at least partly to SAFs, but that needs confirmation looking at asthma deaths in a very careful way, which hasn't been done. When you look at patients with severe asthma, and this is a UK-based study, 66% are sensitized to one or more fungi and 45% to Aspergillosis fumigatus. So the rates of sensitization as you get more severe asthma are more frequent, and that's why this is probably quite a common disease. And it responds to antifungal therapy like ABPA. We're missing sensitization data from a large number of countries. You can see most of Africa apart from South Africa, most of South America apart from Brazil. So until this work is done, actually we won't have a really good estimate of the number of patients with ABPA and SAFs in many countries. Fungal Rhino-Sinusitis is also pretty common. There's a lot of people around the world with chronic rhinitis, and 1.3% are thought to be fungally related. This is not a terribly severe disease for most patients, and so it doesn't come under the radar, comes under the radar a lot, but we think there's maybe around 12 million patients worldwide with AFRS. They've looked at it quite carefully in Israel, and about half the population are affected there. And a very good study from India looked at a population in two large community areas, and they found a population prevalence of 0.11%. So that's around 1 in 1,000 patients in that community in India with AFRS. So it's a relatively common problem. So then you come to the invasive diseases, and invasive aspergillosis affects patients almost completely who are immunocompromised of some sort, and in Europe and the USA and Japan you can count those patients, and there's at least 10 million at risk, and worldwide probably over 300,000 annual cases. And even with treatment, the overall mortality is around 50%. So this is a significant problem. And without treatment, it's almost always universally fatal. So roughly 10% of leukemics, the rates vary from around 6% to 15%. Stem cell and solid organ transplants. There are two estimates for COPD patients admitted to hospital, 1.3 or 3.9% of those patients. So not in the community, but in hospital. Lung cancer, nearly 3%. AIDS, a 4% rate at autopsy. So probably misdiagnosed as tuberculosis or chest infections or Pneumocystis in many cases. Liver failure. And a recent data suggesting a higher rate in severe influenza of 16%. So these are the influenza patients who arrive in intensive care or and are very ill. And so you've got these groups of patients with low risk, multiple myeloma, COPD, and so on, with around 1 to 3%, 4%. Then you've got intermediate risk with higher rates than that. And then your high-risk patients, including the genetic disorder, chronic granulomatous disease, and allogeneic stem cell transplants, and patients with persistent neutropenia are particularly at risk, as well as influenza. And when you look at the rates, you see these are much lower than allergic aspergillosis or ABPA, with rates as high in Vietnam of 16 per 100,000, but rates over here down in these other countries where it's difficult to estimate because you don't have very good denominator data and there aren't transplants going on and so on, around 1 per 100,000. So probably a less common infection, but these are not, because the diagnosis is difficult, they're not very accurate. Invasive candidiasis, there's a lot of patients, probably 750,000 people with this disease. Blood culture is only 40% sensitive for candida in the bloodstream and disseminated candidiasis. So there's probably more cases than are actually diagnosed, and therefore that might be up at 1 million. About a third of the patients, sometimes half, are in intensive care, but there are other patients occurring on the wards as well. Mortality is 30 to 55%. A much lower number, but significant number, of patients with candida peritonitis or intra-abdominal candidiasis, if you prefer, post-surgical patients, COPD patients, chronic peritoneal dialysis patients, with a similar mortality as invasive disease. And there's lots of risk factors, which I'm not going to go into in any detail today, for invasive candidiasis. Antibiotics and multiple antibiotic courses is one thing. Having catheters in, patients who've had major abdominal surgery, pancreatitis is a big risk factor in those patients. Neonates and total parenteral nutrition are some of the major factors. And the rates per 100,000 vary a lot. So there are quite a lot of countries where we do have reasonably good estimates of the frequency, from 5.9 in Uzbekistan up to 21 per 100,000 in Pakistan. When we have an estimate of 5, that's because we don't have good local data, and that's just using a generic international number. So that takes you down to here. And then you've got some countries with rates a little bit lower than that, Germany and France and Canada and the Philippines and so on. So cryptococcal meningitis, mostly in AIDS, but not completely. In parts of Southeast Asia, a quarter of the patients may be related to non-HIV rather than HIV. But there's thought to be about 230,000 patients with HIV and cryptococcal meningitis. This has been going down, fortunately, because of improved antiretroviral therapy, but we're still seeing a lot of breakthroughs in patients on antiretroviral therapy. So just delivering antiretroviral therapy alone isn't enough to completely reduce this disease. The mortality is high, and it accounts for around 15% of AIDS-related deaths. And this rather bizarre map here is a map where the size of the country relates to the number of cases, and is rather strange. And you can see that about 75% of the burden of cryptococcal meningitis is in sub-Saharan Africa, and about 20% in Asia and Pacific. And then the rates are much lower after that. Pneumocystis pneumonia is clinically diagnosed a lot, but not documented in many patients, particularly in areas where the diagnostic tools aren't available. And there's thought to be about 500,000 cases, around 400,000 in HIV and 100,000 in non-HIV. As countries become wealthier and their GDP increases, so pneumocystis rates go up. And if you then get into Europe, you find that 5 or 6 times as many cases are in non-HIV patients as in HIV patients. So the pattern is different in different countries. It is an AIDS indicator disease, and your mortality is between 10 and 30%. It's slightly higher in developed countries, but with high-dose cotrimoxazole or Cotrim, the mortality can be brought down if the diagnosis is made well. The mortality in non-HIV patients is higher at around 50%. And so you've got rates here which vary substantially. So very high rates estimated in Nigeria and Kenya, where there's a lot of HIV, and then very low rates, less than 1 per 100,000 in many, many countries, which are more developed with well-developed HIV services and most patients on therapy. Although some of these estimates, of course, are not perfect as they are for other things. So mucormycosis, one of the most life-threatening fungal infections, is fortunately fairly rare in most places, with around 2 per million people in the US and less than that in France, but appears to be very common, or much more common anyway, in India, probably because of diabetes. And it's uncontrolled diabetes, as well as actually just having diabetes. It seems to be a risk factor in India. Deferoxamine therapy, chelation therapy, and burns are risks as well. And then you've got lower frequency risks in organ transplantation patients, particularly bone marrow transplantation and neutropenia. And you can have implantation injuries as well. Histoplasmosis is very variable in frequency, and so you need an estimate by locality. So some of the countries you can see from very particularly common in Guatemala and the Mississippi Basin in the USA, and there are other parts which with hyperendemic for histoplasmosis as well. And so there's thought to be about 500,000 new infections every year from people acquiring histo in different parts of the world, although that estimate is many years old and not very well founded. And then in the US, there's thought to be about 25,000 symptomatic cases, and there are many other symptomatic cases across Latin America in particular. Our estimates for Africa and Southeast Asia are really not very good, and we don't have really any good estimates of the numbers of cases. In disseminated disease, the mortality is very high unless the diagnosis is made early, and it's often mistaken for tuberculosis, and because then the diagnosis is late and patients die. So it's a particular problem. So our methodology for estimating the burden is not perfect. It's based on registries, it's based on high quality epidemiology studies, such as cryptococcal antigen surveys, of which there are many, tinea capitis studies in schools, of which there are many, and then modelling based on underlying disease. So that's how most of these estimates have been done. Some have been done by counting the number of cases, but of course that is, unless you've got very good diagnostics, that's not always very accurate. And what we haven't got for many countries is trends over time, because doing these epidemiology studies multiple times is tricky. There's a problem with a lack of diagnostics in many places, such as fungal blood cultures, antigen tests. So actually the estimates are poor in many places or non-existent, and that's a problem. And so all of these estimates are estimates. They're by no means perfect, and that produces a problem. But you can see, if you like, a sort of a broad summary around the world, taken from a summary paper that we published last year. And you can see the burden on the left-hand side relates really to prevalence, and you're up at 1 billion for skin and soft tissue disease. Your recurrent vaginitis is probably the second most common problem. Fungal Rhino-Sinusitis and SAFs and ABPA are relatively common as well. And then on the right-hand side, you've got oral candidiasis, esophageal candidiasis, invasive candidiasis as the top problems, and then less frequently, probably histoplasmosis, pneumocystis, and invasive aspergillosis. And probably the estimate of an acute histoplasmosis relates not just to disseminated disease, but all the forms of disease. and that it probably overestimates the number of symptomatic patients. But this is where the difficulty comes in trying to make a perfect summary. Thank you very much for your attention.